I didn't get it, huh?
Okay.
Good morning, everybody. It is Wednesday, February 11th. We're continuing on budget and budget recommendations. And this morning, we're starting off with Vermont Medical Society. So Jessa and Dr. Morris, you wanna?
We will be take one turn.
Okay.
Yes, I think Dr. Morris may look like she's on the schedule twice, but she's really second on AHEC. So,
Okay, got it.
yes,
So
there were some schedule moving pieces this morning. Yes, exactly.
Great.
That's that word, but we are coordinated but separate. So good morning. And she is right here in the purple jacket.
I was seeing if you were coordinated.
Oh, no, not literally. We could have done that. We did not color coordinate this. Good morning. Thank you so much for having us this morning. Jessa Barnard, the Executive Director of the Vermont Medical Society, and also sharing this testimony on behalf of the Vermont Academy of Family Physicians and American Academy of Pediatrics Vermont chapter, so Vermont primary care clinicians. I won't be exclusively talking about primary care impacts, but largely this is really about both some downs in the budget that we have real concerns with and some additional needs to stabilize primary care. And I want to acknowledge right up front, because I know you've heard a lot about the RHT grant already, but there are reasons we're still here asking about budget items because RHT funding, as I'm sure you have heard many times over, can't go to base rates, can't go to sort of provider based payments, and also can't supplant budget items. So we have a real concern with if these are cut in the budget. To us, it looks our understanding is we can't then just say, oh, but RHT can cover it, because that looks like we're sort of replacing budget funds with RHT funding. And some of the items just wouldn't even be eligible for RHT. Like we'll talk a bit about loan repayment. So we're here both to talk about some base funding for primary care and some workforce items. And as I mentioned, I'm tag teaming a bit with Dr. Ann Morris from AHEC. She'll really be getting into the details of the workforce items, but I just want to say how important they are to the primary care clinicians of Vermont. And we absolutely support the rescinding the cuts to the AHEC program. So I don't have I don't have slides. I have a one page, well, actually 2-page, I guess, front and back handout that should be posted with some arrows in both directions. We hope this visual helps. You can let us know if this is helpful or not. We were trying to kind of keep it simplified and high level. The first two items are about cuts in the governor's recommended budget that we strongly oppose. So as I mentioned, there are cuts to workforce, primary care workforce programs, and Anne will go into more detail. It includes loan repayment, early pipeline programming, and physician placement services. And I think we've all had the experience of struggling to get a primary care clinician, find a new one if yours retires. We know many primary care clinicians are nearing retirement age. I think I'm a bit preaching to the choir, but I will just say our organizations strongly oppose eliminating the state funding for these programs. It would eliminate really almost all of the funding for these services. And again, we don't think RHT can be a replacement for them. Especially the loan repayment. We have heard very loud and clear from AHS that CMS has said no, loan repayment is not an acceptable use of RHT funding. So we oppose those cuts. There is also in the budget, and I think you've heard this from DVA, Vermont has had, as many of you know, sort of a aggregator of payments, One Care Vermont, our statewide ACO. That sunset at the end of 2025. There are some programs they're still helping to administer for 2026, but the all-payer model and our ACO that took payments from different payers and paid them out to primary care and hospitals and others is over. And so DVA had contributed to that as well. All payers kind of paid in, Medicaid, Medicare, some of the commercial payers, the hospitals were also assessed dues. And then there were several primary care programs that then went to help support offering primary care services and stabilizing our primary care practices. DVA in their budget sort of books this as savings, but ending $5 million in gross payments to primary care programs. That was being paid practices. That was going as a $4.75 per patient per month, per attributed patient per month payment to primary care practices. We understand, DIVA's reasoning or rationale is that with the end of the ACO, they don't have a mechanism to get those funds out the door. Our ask is to direct those to still be going to primary care practices, even if it's not through the ACO, that DIVA directly pays primary care all the time. They in fact have a separate, and I'll talk about this a little more, sort of a higher, what they call conversion factor, a way they pay primary care practices already more than specialty care practices, so that we would ask that funding, even get it, since that rather than just book that as savings, we should keep those payments in the primary care fee schedule.
I have a question about this.
Yes.
Because I'm confused. And
Yes.
this may be a question for Diva that I didn't ask the other day because I wasn't thinking about it. So $4.75. There were two per member per month. There was the blueprint per member per month, which are goes to NCQA blueprint practices.
Yeah.
That was always flowing through. Well, first it used to flow through blueprint, then it was flowing through the ACO.
Yeah.
And there was also a Medicaid management per member per month that has been in existence for as long as I can remember. And that used to flow straight through DIVA.
Correct.
And then I think
Yeah.
it started flowing through the ACO.
They merged those two payments into one through the ACO. Correct.
So is this the elimination of the blueprint per member per month, or is it the elimination of the Medicaid management fee, which
Yeah, that's a great question. My understanding, and it would be good to clarify with Diva, my understanding is this is not the blueprint per member per month payment, that is, I have never heard Diva say they don't plan to continue their participation in the blueprint programs and their blueprint per member per month, that this was their sort of primary care management, job taking care of your patients, fee but it's a good point. At one point, $1.67 that they used to pay directly to practices separately that then got wrapped into the ACO payment. So it's the ACO payment and that management fee, I think, would be this channel flowing that was going through the ACO. Part of it used to come directly from the blueprint. The blueprint still has PMPMs. So,
it's just, I'm concerned because they're saying, well, now that the ACO is gone, we can't administer it, but it used to always come through DIVA.
Directly through DIVA.
Directly through DIVA.
Yeah.
It would come every single month on a remittance advice.
Correct. And I think they're going to have to go back to paying their blueprint PMPM themselves too. I think they're working on that. My understanding is they're working on that mechanism because the ACO was administering that for them and can't do that anymore either. So they are, my understanding is DIVA will be doing some PMPM payments to primary care.
Okay.
But just
clarification on that. Yeah.
per member per month. So for whichever payer, it's their, for each Medicaid patient that goes to that practice, they are making that payment per month. They sort of add it up into one payment for this practice has 200 Medicaid patients. So we multiply 475 by 200 and pay that practice kind of with their month. And as we were talking to the chair about it, the OneCare, the ACO helped to kind of flow those funds at one point, but before that it was Medicaid directly paying some of them. And my understanding is they will be going back to doing that.
Okay.
Yeah, thank you. Thanks for the questions. So these are both proposed, I will just call them cuts, in the governor's recommended budget that we oppose, both the workforce and the kind of has become really a base payment to primary care. If you're ready, I will move on to another item. So this is not addressed really one way or the other in the governor's recommended budget. The first one being the sort of traditional way, the fee-for-service way that Medicaid pays for professional services. And I know your committee has gotten a little bit into the distinction of kind of how different types of providers are paid and that there's sometimes facility fees, sometimes different types of fee schedules. So what I'm talking about is the fee schedule from Medicaid that goes to individual clinician services. So your physicians, PAs, APRNs, and wherever they are, providing services to Medicaid patients. That fee schedule, DIVA typically bases on Medicare's fee schedule. So every year, January 1, Medicare publishes a new fee schedule that has both a lot of detail in terms of how certain services are assigned kind of like I call it like a work value, like how much effort goes into providing that service. And then they multiply that by what's called a conversion factor, like a dollar amount multiplier. So Medicare publishes that, and DIVA typically follows those changes to the codes to keep the fee schedule updated. It's a lot of work to go through. I mean, there are thousands of codes. It's every type of, your office visits, your mole removals, your all sorts of things go into that thousands of lines of codes. So DIVA updates their which codes they include and how they value them, along with Medicare, but then they use their own state-based, I'll call it their conversion factor, their number that turns that into a dollar amount that the practices get paid. So this year, what they have proposed, and in fact, what went into effect January 1 already, is they updated all their codes like that, but then they adjusted their conversion factors to be budget neutral because that was their guidance. This committee has done a lot of work around this issue in the past and requested that DIVA provide additional analysis of what other options would look like than just a budget neutral fee schedule. One of them is what it would look like to add a inflationary index to how practices get paid, because that practice expenses go up, how much it costs to pay your staff, to keep your lights on, your health insurance for your own employees. It's very expensive to run a medical practice, to provide medical services. So DIVA did provide us the analysis of what it would look like to match what is a federally Medicare published annual, what they call economic index. That's the federal government's estimation of what it costs more to run a practice this year than last year. That is 2.67% for 2026. And that is what we are requesting that the professional fee schedule receive. That comes out to 3.3, that middle box in the middle of the page, that's 3.31 million gross. Of that, only 788,000 actually goes to primary care, the way it breaks out, 529,000 to specialty care, and actually almost 2 million to psychiatric codes, mental health codes. If you are interested in more detail, some of you may be, some of you may not, on the back sheet page or the second page is the breakdown of how which goes to primary care, specialty, and then even more detail of like ups and downs within the types of services, because of these two factors at play, not just the dollar amount, but how they value codes. So there are sort of from Medicare that DIVA also imports. So there are winners and losers, I will say, within that. But that is the ultimate sort of, if you added the inflationary adjustment to help practices stay open, keep their doors open, pay their own staff, that is the total amount that would come out to. I will say if DIVA stuck with what they've proposed, which is a budget neutral, they call it budget, it's actually a teeny decrease. That is a reduced, sometimes we've measured where Vermont's fee schedule is relative to Medicare. The budget neutral is actually a reduction relative to Medicare, because this year, for the first time in actually quite a long time, Congress is requiring Medicare give a slight increase to their professional fee schedule. So we would go for primary care services, for example, 114% to 110% of Medicare. And for specialty services from about 80, it would be about 86 to 85%, I believe, with the budget neutral approach. With the inflationary approach, we stay more even to Medicare, where Medicare, like the percent of Medicare would stay about the same, because this is about the inflationary factor that Medicare is also adding in this year.
So for 2026, Medicare's conversion factor went up.
Actually went up. Congress required, I know, usually we're in this committee, the chair is asking that question. We're often saying, don't do what Medicare does, because Medicare's had actually decreases year over year for complex, like federal formula reasons. This year, Congress actually is requiring about a 2.5% increase to Medicare.
And yet Medicaid
It's not matching that either.
Is keeping the
Right.
exact same conversion factor.
Their own same convert, yeah. Well, I think it's actually, there are some slight changes because of all the, all the RVU adjustments. But then they adjust their conversion factor to be budget neutral, is what they're, proposed for 26.
Okay.
Or well, calendar year 26, FY 27, fiscal year 27.
Did we do some work a couple of years ago on trying to untie
Yes,
Medicaid to Medicare by essentially taking out the conversion factor piece,
yes,
stop tying the conversion
And
factor
they-
to Medicare?
correct. And they are not, they are not tying their conversion factor to Medicare. But I think they were, obviously they have to follow their budget
Yeah.
guidance. And I think their budget guidance was most of their fee schedule. There are, I think with very few exceptions, almost all of their fee schedules are proposed to be budget neutral for this year. Except ones that I believe, there are a few where it's federally mandated for, like for example, the FQHCs, I think they are required to include a inflationary adjustment for I can't answer this authoritatively, but I've been watching as they've come out with their fee schedules, the vast majority look budget neutral for this year, including this one. So yes, they are not pegging it to Medicare. They are sort of doing their own. And I will say you did do some work asking them to look at various scenarios. They did send those over to me and I'd be happy to share them. This was only MEI, the inflationary index was only one. They sort of looked at various models and provided us that information. So I appreciate that they are sharing the analysis. Their ultimate what is in the budget is a budget neutral approach.
Okay.
Sorry.
You have a question?
Clarification.
Yes.
I'm looking at your chart.
Yes,
Thank you. But it's a lot of information and
yes,
stuff I don't know. Acronyms I don't know. Like
sure,
EPCP.
sure. Yeah,
I
thank
don't know if you
you.
want to spend time on that, but I'm just.
Oh, I'm sorry. Go ahead.
Go ahead. So so this is the second page of my testimony. It's a chart from DEVA. So again, much appreciation to DEVA for providing this because it's the only way I understand what the ups and downs are each year. So this is if you added a 2.67 inflationary factor, the EPCP is the enhanced primary care payments.
Ah,
So they have a different conversion factor for primary care codes than specialty codes. The second line, so that shows the way it would break out if it was a 2.67% overall increase is actually 4.74% increase to those primary care codes. If you remember, it's primary care, there's sort of a dual taxonomy. You have to be a primary care provider providing certain services. So if you fit in that bucket, you get this different paid, fee schedule or different value of your fee schedule. So that would be a 4.74% increase. Non-EPCP, that's basically specialty care services, would be a 0.71% increase. And then for the first time this year, they've broken out psych and mental health services separately just because of the way Medicare has been revaluing codes. We've noticed over the past couple of years that any increases to primary care, it was sort of how we define primary care, actually looked to go quite a bit to those codes. So it was just to take a look at kind of how that breaks out, that why they're listing that separately. It's the same. So that's and then below that is breaking it out in more detail. Again, the primary care on the top line, specialty care second line, and then within specialty care, how that kind of breaks out. I will say even with a inflationary increase, it is actually a decrease to OB, and that is concerning to many of us and again, that's because of how Medicare, because of the two-part formula, how they revalue the value of codes and then how they pay for them. So that's not the conversion factor problem. That is Medicare is trying to kind of give more work points to office-based services than kind of procedural-based services, which in concept is a good thing. It's meaning things like primary care and services that take a lot of time talking to patients. They're kind of over time recognizing surgical procedural services where maybe getting more relative to talking to patient type services. So but OB is one area we have concerns about how that impacts in particular.
Is it 26 or is it for 27? Aren't there some big changes coming with OB, the event? Basically getting rid of the bundled global OB services. I feel like I heard that somewhere.
I'd have to dig into, I don't know that was for 26,
Okay.
Medicare 26 fee schedule. And I will say we have clarified, like OBs providing, OBs can fit in that primary care fee schedule, but remember, it also has to be like primary care services. So things like labor and delivery do not fall in that bucket. That's actually been something, if this committee is interested, that we've suggested, is that sort of all OB services included, like at least that labor and delivery should actually be considered a primary care service, in which case it would get the enhanced payments, and that would really help our birthing units and if we have a birthing center, it would help everybody who does those services stay in operation. So
January 1st, 2027, it's changing.
oh, thank you. Appreciate that. Next year.
That should actually be a good thing.
Yes, that could help with, because OB services, they bundle together all of the prenatal visits and the delivery and the couple postpartum visits into one payment, and it hasn't been adjusted very much over time. In fact, it's been going down. So it's been really one of the reasons it's been very hard to sustain birthing units, regardless of where they've been located. Okay, I'm conscious of time here. I think the one more kind of detailed one, the others are much easier to describe. We've done a lot of work with the legislature, this committee, and others to talk about kind of the impacts of the ending of One Care Vermont, the ACO I've mentioned. Regardless of your opinion of the ACO, one thing they were successful at is directing more payments to primary care. Sort of being that aggregator, using not just payments from the payers, but actually hospital dues on top of that to pay primary care in different ways, more than they were getting paid before. You and the full legislature did really helpful work last session to help fill. So kind of what we've been calling a gap in funding between the end of the ACO and if we join the AHEAD model in 2028, the start of the AHEAD model, which would bring, we hope optimistically, some more funding to primary care. So the legislature directed some funds to fill that 2026 gap. There was actually a pretty big settlement with the UVM Health Network and Green Mountain Care Board, which directed substantially more funding to fill that 2026 gap. So we feel actually pretty comfortable that sort of the loss of funds to primary care are covered until the end of calendar year 2026. So the time frame we're really looking at is January 27 through June 27, so half of the fiscal year. There is no plan for how do we sustain primary care practices until 2028, again, when we potentially join the AHEAD model.
Have practices started seeing those payments from the UVM settlement?
I believe that's a great question. I should confirm. They were planning to make a payment towards the end of January, and I should confirm if that's gone out. They're two. So One Care was making them in monthly payments, sort of payments. In all of this settlement, One Care is actually one of their sort of things they agreed to do, even though they're closing, is to make two more payments to help get this settlement out the door to practices. As far as I last spoke to them, their plan was a January payment and a June payment to divide like a year of payments into two to help practices make up the loss of those funds.
I just want to go on record as saying that UVM settlement was not bridge funding. It was never intended to be bridge funding. It was intended to be UVM excess revenue going to places that were needed. But I don't like the idea that it was supposed to be ACO bridge funding. So I just want to put that.
I don't think any of us,
But
yeah,
that's not.
I will defer that decision making to the Health Network and the Green Mountain Care Board. That was that was not a legislative And I will say, we do appreciate, I mean, regardless of the intent or use, it has been important to fill that need. It is sort of, it will be helpful to sustain practices for the full calendar year, because the legislative funding that was directed last year in the budget was a partial fill of that gap. And then the 11 million really did finish filling that gap and include other partners who had worked with the ACO, like DAs and SSAs and home health, that might not otherwise have been received that sort of gap funding. Okay, last two things I will mention quickly. We strongly support, so there is a medical student scholarship program, which Dr. Morris will talk more about. That has a legislative in language sunset of 2027. We strongly support removing that sunset. There is language to do that also in S-197, the sort of primary care reform bill that's getting some testimony in the Senate, but I personally would love to see it in multiple places, not knowing exactly what's moving where this session. So if that could go in budget language, that would be very helpful and make sure it's really moving. That scholarship has been really helpful from our understanding, and I'll again let Anne give you more of the details, but at least to remove that sunset to allow it to continue moving forward would be great. And then there is a program working with pediatric practices, Dulce, which embeds family support specialists in certain practices that really helps join the family through each of their visits and help screen for social determinants of health, make sure they get the referrals where they need. It's sort of like an almost more intense version of the blueprint, I think of it. And that program does not, from my understanding, have any source identified currently of ongoing funding to keep it working with the 6 practices they're working with.
Is that being funded through the Blueprint? Is
It
it?
is not getting, it's getting funded, I believe, maybe through the mental health integration pilot. And I don't think that is planned to continue, is my understanding, is that there's no sort of continued plan, like opportunity or availability of funding from the Blueprint or elsewhere. And I am not the expert on Dulce. I can definitely, if folks are interested, connect you, or I'm sure that folks involved would be happy to provide more detail and testimony. But we do think that the pediatric practices working with those family support specialists have really valued the service and think it really is helping their families. And they're often working in conjunction with the family support centers in their communities.
Copper, did you have a question?
Yes, thank you, Madam Chair. How long has the program, the scholarship program, that has 22 scholarships to date, how long has that been in effect?
I will let Dr. Morris give you the details. I should know that off the top of my head because we were in 2022. I was going to say, I think there was a 5-year window before the sunset went into effect. So 2022, with the intent that the legislature, I think, put that in place, wanting sort of data on how it's working. The challenge is that if you think about medical student training, they're a medical student and then they go to their residency before they could even start paying back their service obligation to Vermont. So the students are just starting to come back to Vermont now. So fully understand the legislature may want to see sort of effectiveness and how it's working before, not having any check back, but it's just with this sunset, it's too early to even really have meaningful data yet because those students, like the first class is just finishing their residency now. So it's sort of a sunset before we can even show you the data on the full data on how it's working or getting many of them back in Vermont. Thank you all very much. Oh,
Yeah, go ahead, Leslie.
I just want to make sure I understand your chart. So,
front page or back page?
page.
Yes.
So I see what's not in the governor's recommend.
Yes.
So that's the 3.31. That's what you're saying here. But your ask, I'm trying to make sure I understand what your ask is, because I'm not getting it. Sorry.
We have a number of asks,
Yeah.
both to not approve or to oppose or restore the funding that the governor is proposing to cut,
Okay.
and to fund the items, the increase to the fee schedule and continuing those
So is the
population health
ask on the
management.
right side, like what's
The asks are all in the middle white
Okay,
boxes.
the white boxes.
The white boxes are the asks.
Okay. So you're not, just remind me about the scholarship, that There's
The scholarship, so, and again, I'm deferring a lot of the detail to Anne, but my understanding is that there is rollover funding because not all of the scholarships have been, you could say, used, like not, there's up to 10 per year and not up to 10 students have applied each or been awarded the funding each year. So even if we didn't add more funds, but at least allowed the program to continue, it could continue to use those rollover funds for a certain amount more time, not indefinitely, but
Because
there are
there's somewhere in here, which I have not seen and missed, that there's a recommended sunset for the incentive scholarship. Okay.
right. It's not, because it's in session law.
Okay,
So you wouldn't necessarily see that in the budget or
okay, so that's why it hasn't come up in front of us somewhere along the line.
that is why we were bringing it to your attention.
Okay, got it.
It was in there when the funding originally passed and when the authorizing language creating the scholarship passed.
Yeah,
So it is in legislative language that there is a sunset and we're
Okay.
just asking
So
for
you're
that
just-
language to be repealed.
okay, got it. Okay.
Can I ask you about the CPR payments?
Yeah.
CPR payments, if I recall through OneCare, they were like the larger global payment.
Correct.
They displaced fee for service. But there were only a couple practices on those.
There were 19 practices and what we've been asking for the kind of what you could consider bridge funding is on top of fee for service, not necessarily.
It's like, because aren't they just gonna revert back
Correct.
to?
They have already 2026, they reverted to fee for service. This is kind of keeping them whole for what they were receiving above fee for service.
Okay.
Yeah, because they were getting a capitated kind of global payment from the payers, which is also unfortunate that it went away. And hopefully we will have an opportunity later this session to talk to you about S-197 and trying to move primary care payments to more capitated payments for everyone.
So another question, I'm curious to know, is there private equity in any of the primary care practices that we're thinking about?
That may be a question for the blueprint. I am not off the top of my head. I am not aware that the primary care practices I know of that work with, for example, MSOs are I'm not aware that they are in the blueprint. They tend to be more direct primary care or concierge practices. Though I don't know, and to be in the blueprint, you have to meet patient-centered medical home criteria. And I don't know, my sense is those practices are either can't or don't choose not to kind of meet those criteria.
The blueprint, yeah, so I'm thinking about blueprint practices and you're saying likely not them. And how about other practices outside the blueprint world?
So like the bridge funding, for example, that we're talking about, is going to, I'm just trying to do my analysis here. So that's going to practices participating who had participated in OneCare. The DIVA professional fee schedule, there are direct primary care practices who accept insurance, right? So concierge typically does not, direct primary care does, and then also charges a sort of like subscription fee on top of that. So if they see Medicaid patients and accept the Medicaid fee schedule, you could have a direct primary care practice who also works with an MSO who helps provide administrative services, billing supports, that kind of thing.
But you're not aware of, I mean, that's what I'm curious about. Is it happening? Or I could see what you're saying.
I am not aware.
It might be happening.
It
or
might.
could be
I am
happening.
not
Is it
aware.
happening?
I am not aware. I don't have direct knowledge that it is or is not. I don't think other than the direct primary care practices working with MSOs, I am not aware personally of any primary care practices in Vermont owned by private equity.
Thank you, Jessa.
Yeah, thank you very much. Thanks for your time.
Dr. Morris, come on up.
My feet touch the ground. Isn't it great when that happens? Good morning, Chairwoman Black, committee members and guests. Thank you for allowing me here to speak today on behalf of the Vermont AHIC Network. I'm Ann Morris. I'm the Associate Dean for Primary Care and AHEC at the Larner College of Medicine. And before I go on, I also want to introduce, I have some students that are with me today. This was not on purpose. We had actually planned on being here as part of a 2-week AHEC Scholars Elective called Community Engagement. And part of that is looking into medical advocacy and how, as primary care providers, that's part of our responsibility as professionals. And so we had planned on being here today. And so that's why we're here. It just so happens I'm also going to testify. 3 of these are 4th-year students who are actually going into primary care. So going into family medicine, well, we presume going into family medicine, pediatrics, and obstetrics and gynecology. So that's actually really exciting for us. So some of you already may know me from my previous advocacy efforts around reducing administrative burdens for primary care providers, including testimony here on prior authorizations and step therapy. 2 weeks ago, while testifying on S-197 before the Senate Health and Welfare Committee, I urged the total legislature to really invest in primary care, knowing that to some it may feel paradoxical to dedicate more money into a system that seems to have exponentially growing costs. But similar to adding oil to your car to make the engine run more smoothly, investing in a primary care system that values preventative services, community continuity of care, and the flexibility to provide comprehensive care through interprofessional teams that are built to meet the needs of the individual communities will not only decrease the total cost of care, but will also improve healthcare outcomes for all Vermonters. Now, the purpose of my testimony today is not to convince you that primary care is important. I think you all know that already, but rather to acknowledge the complexity of creating a primary care delivery system in its entirety, and to ask you not to lose sight that in addition to building the system to provide care, we in parallel need to have a system that develops, trains, and supports our rural primary care workforce. Attached today, I have a couple of infographics that are going to talk about our AHEC programs. We'll specifically talk about something called our educational loan repayment, and then includes testimonials from many of our recipients. So that is, you may have those in front of you. We know that nationally, fewer people are choosing careers in primary care compared to other healthcare specialties. We know that lack of salary parity, high educational debt, and administrative burdens contribute to the reticence to choose primary care specialties. We know that this is compounded in rural locations by having a small pool from which to entice students to enter into healthcare fields. To address the primary care workforce shortage, a variety of methods are used to increase the chances that a healthcare provider will choose to practice in a rural location. These include early exposure to healthcare career exploration through primary education like middle school, high school, as well as rural training experiences in both medical schools and residency programs. Evidence shows that residency training at teaching health centers, such as the now funded Maple Mountain Consortium, significantly increases the likelihood that physicians will practice in a rural area post-residency, very often, as in the vast majority of the time, within 100 miles of their training site. We also know that scholarships and loan forgiveness, such as the Vermont Educational Loan Repayment Program and the AHEC Scholars Student Incentive Scholarship, benefit recruitment and retention in rural areas. I'm just going to say the AHEC Scholarship for that from now on. To help states address this workforce dilemma, HRSA developed Area Health Education Centers, AHEC, to address healthcare professions shortages, especially in rural and underserved areas. AHECs in 44 states strive to provide programs that address healthcare recruitment and retention, health professions training, health professions support, meaning continuing education. In 1996, with encouragement from this Vermont legislature, UVM Larner College of Medicine created the Office of Primary Care to show its commitment to primary care in Vermont, which led to the establishment of the Vermont AHEC network. Today, this network consists of a program office and which is the administrator of the HRSA grant at UVM, and then 2 centers, Northern Vermont AHEC and Southern Vermont AHEC. It's funded by HRSA, the state through VDH, and our 14 hospitals. As a network, we strive to provide statewide healthcare professional development programs to ensure that all Vermonters have access to high quality primary care. Our early pipeline programs are how we grow our own healthcare workforce. In the last 5 years, we've hosted activities in 46 schools and other venues, leading to nearly 20,000 student interactions, 76% of which have occurred in rural communities. For comparison, or for scale, Illinois' AHEC, which has 9 centers, reaches about 2,000 students annually. This includes career exploration workshops in schools, after-school career pathway plannings, near-peer mentoring programs, which I think is really important to state near-peer, between high school or college students and our medical students, and summer immersive and residential healthcare enrichment programs. These programs have led to technical certifications such as CPR, Stop the Bleed, and the Vermont EMS first responders. In the last few years, we've certified 95 new Vermont EMS first responders. Further, of the 52 alumni from the Governor's Institute of Vermont Health and Medicine Institute who have achieved secondary degrees, 28 have graduated from a Vermont college, and 36 have earned a health-related degree. So these are working. In medical school, the AHEC Scholars Program reaches 79% of the LCOM students. The AHEC Scholars Program is a voluntary, enhanced curriculum that allows students to increase knowledge, strengthen leadership skills, and gain competencies with the goal of learning about community medicine, social drivers of health, and how to provide whole person care. 39% of those enrolled students complete the 2-year commitment above and beyond their actual curriculum and graduate with the distinction of being a National AHEC Scholar. Further, our data shows that from 2022 to 2025, LCOM students who completed the AHEC Scholars Program were 2 times more likely to enter a primary care specialty compared to their peers. Further, at the Vermont AHEC Scholars Medical Student Scholarship Loan Incentive Program, that was created by statute as a $1.4 million grant to provide up to 10 in-state tuition reimbursement awards per year to 3rd and 4th year medical students who are entering primary care and agree to a year of service obligation in Vermont, in a rural Vermont location post-residency. So for each year of the award, they have 1 year of service obligation, essentially outside of Chittenden County. We have currently granted 25 awards. We have seen an average of 3 to 4 awards per year, though this current cycle, which ends today in terms of the application, has at least 6 and up to 8 applicants. So we're seeing an increase. And I anticipate this interest and commitment to the program will increase as the changes in federal student loan caps and the public service loan forgiveness programs come down the pike. By statute, this program will end in June 30, 2027. And this is what we'd like to ask you to extend. Currently, the fund has approximately $476,000 still in it, or 11.9 awards. So if we give 6 or 8 awards, we'll still have 5 to 6 awards that we could give next year. And hopefully we will, hopefully we will be able to get the legislature to further fund this award in the future so that we can continue to award these in the future. The Vermont Educational Loan Repayment Program, or the ELR program, for healthcare professionals supports primary care physicians, dentists, and nurses who to receive loan repayment in return for a 1 to 2 year service obligation to a rural primary care practice. So these are outside of medical school. They're now in practice. In 28 years of this program, we've distributed $29.5 million through 3,364 awards. During this time, 37% of state dollars distributed to awardees have actually been matched with worksite dollars. And again, this program works. More than 60% of recipients stay at the worksite after completing service obligations. And finally, our physician placement service is a non-biased resource to medical students, residents, fellows, and physicians who are seeking employment in Vermont. Over the past 5 years, this program has contributed to 62 physician placements, 71% of which were in primary care practices, and 55% of which have been in rural counties. Testimonials from Vermont practices and hospitals have been robust in the services and benefits that this saves them. Saves them individually up to between $15,000 and $40,000 per recruitment on an average, or an estimated savings of over $1 million in recruiter fees for Vermont practices. So our hospitals and our practices are truly benefiting from that. For the brevity and purpose of this budget proposal, I will not review continuing educational services available at no charge to all of our primary care providers. These programs are a 2-year award and not up for review this year. But we'll comment that continuing education services not only support our primary care workforce needs, but also improve the access to medical care in rural areas by helping to increase the scope of practice and the comprehensiveness of the care provided in the medical home. So it helps to keep the care where people are, which is the cheapest, the most inexpensive way to provide care when thinking about the system. So I would therefore like to ask this committee to first remove the statutory sunset date for the Vermont AHEC Scholars Medical Student Incentive Scholarship. And then 2, to provide level funding to 3 longitudinal programs through the Vermont Department of Health that have been removed from the governor's FY27 budget. So those are specifically $500,000 for the AHEC support grant, which helps to fund healthcare pipeline development programs. It's been level funded since FY 2006 and is divided equally between all 3 AHEC centers. And this funding has been despite repeatedly meeting and exceeding our HRSA and our VDH work metrics and outcomes. Second, $667,000 for the educational loan repayment program, which has provided $29 million in loan repayments to Vermont primary healthcare workforce over the last 29 years, and has a proven track record of retaining award recipients long after their 1 to 2 year service requirement. And then $50,000 for our MD placement grant, which helps to support the AHEC's physician placement services, providing unbiased career support to those seeking practice in Vermont. Again, it's assisted 62 placements in the last 5 years and estimated saved over $1 million in recruitment fees. These funds are crucial to support the ongoing work of the Vermont AHEC network in growing and supporting our primary care pipeline. They are unlikely, as you've heard, to be replaced by the rural health transformation dollars, giving restrictions on using RHTP funds to supplant our current programs, as well as the clear exclusion on monies for loan repayments. There is no one-size-fits-all solution for our workforce woes, but lack of providers worsens primary care access, leads to increased utilization of emergency services, and increases the overall cost to our healthcare system. We cannot reform our primary care delivery system without simultaneously investing in our primary care workforce. Thank you.
Any questions? Hi, Topper, and then Leslie, and then.
Before I ask this question, I want to specifically say that I really support this AS program.
Thank you.
I'm not going to ask you any questions.
But
40% of the participants don't stay here. Is that what you said? 60% stay here.
Which
They're there.
in which program? Sorry.
I think it was primary care.
Yeah. In loan repayment. So we know if we look at the 5-year data in the loan repayment, we know that 60% looking at 5 years out are actually still in their sites.
After they've
Yeah.
met their commitment.
Yes,
Okay,
Yeah.
60%.
yep,
40% don't.
correct.
That's the part, that's a lot.
Yeah. I think part of it is recognizing that these funds are going to many different providers. So they're going to MDs and DOs, they're going to dentists, they're going to nursing. That could include APRNs, nurses, LNAs. Specifically, we see in the nursing sector that it can be hard to keep, that is one of the hardest places to keep providers. And that is because they're, frankly, they can almost make more money in a sign-on bonus to move to another job than to stay where they are. And that's something that's out of our control. So the money that they're receiving makes it, the salary bumps that they can receive makes it hard for them to stay.
That's the big reason.
I mean, that's one of the reasons. I think that you also are looking at administrative burden for providers. You're looking at having places for Vermonters to their partners to work, their ability to buy houses. For young providers that are coming out of medical school with a minimum average of $250,000 in debt. And most people would say it's actually significantly much more than that. When they start, they're essentially paying 3 mortgages. They're paying their loans, which are upwards of $2,000 a month. They're paying, if they're starting a family, daycare costs, which could be upwards of $2,000 a month. And then they're trying to have either a rent or a home payment that could also be upwards of $2,000 a month. So it's just incredibly difficult for providers to stay and meet the financial needs of their families.
When you're talking about paying loans, you're talking about the first 2 years of their education, the money they borrow for that.
Yes, well, it's all 4 years of their education for medical school. And then they have a minimum of 3 years of residency training after that. That could be extended in some cases to 4 or 5 years in primary care. And then you also have undergraduate loans, and in some cases, they also have graduate school loans. And sorry to be long-winded about this, but they could have $10,000 to $20,000 that they have paid in medical school applications or in residency applications as they're trying to get there. So there's a lot of equity that we could discuss there in terms of what people are investing in order to become healthcare providers. And it really does take a vocation for them.
Okay, I'll get to Brian in a minute. I got Leslie, I got Lori, and then Brian.
I'm good.
Not Lori.
I don't have a question.
Yeah, no,
Thank you for this. We were told, and you addressed this a little bit, but I just want to make sure I understand it, that this program, it's okay to go away because the rural transformation plan is going to take it over. That was hard to imagine because here's a program that's standing and operating, and what's it going to take to get that program up and do this work? But now what I'm hearing is that it's not legitimate use of the money anyway. So that's done, right? That idea, let's just say that. Am I understanding that right?
That is correct. So there are some very small parts that we may be able to submit RFA fors. RFA. So that we may be able to submit applications for grants to participate in small parts. But this funding goes away and will take away there is nothing about early pipeline development or health careers exploration. The vast majority of the RHT programs are really looking at post-secondary certifications and accreditation programs and things like that.
So you mentioned, I can't remember, did you say 19 states have this, have they had, or how many?
44 states
Sorry.
and several of our territories.
And are they all funded by legislative
They,
grant?
they all are HRSA grants.
Okay,
And then you have to have matching monies that are coming from the state. That could be state funds, that could be gift funds, that could be a variety of ways. Most states provide state funds
in the same model that.
in the same, yeah.
Okay.
The benefit of AHEX is that they can be innovative in each state.
So I just want to be, and I know Brian has a question and Daisy, but I want to be clear. If the state removes our money, you lose your HRSA federal grant.
Correct. We are at risk of losing that. Correct. Correct.
And how much is that altogether?
Um,
I'm sure it's here somewhere.
It's a 5-year grant fund, which I believe is $4.2 million from HRSA that comes in annually. And then
4
we
million
match
annually from HRSA.
4 million over the 5 years.
Oh, so not
That-
annually, but
Correct.
it's divided by 5.
Is it a 1-to-1 match?
Is yes.
Brian, did you have a question?
I do, thank you. Can you hear me okay?
Yes. Can hear you well.
Yeah, I was hoping to get there in person to ask you, but I think you're gonna end minutes before I get there. So I wanted to ask, you mentioned, well, there's 2 questions. One is you mentioned that the first class, so to speak, or the first cohort maybe is a better word, of folks who took advantage are going to be coming out of their residency soon, and that we're just going to start to see the reward of the investment soon. And I'm curious if you could say a little more, like if we were going to try to measure the success of this program, what would be the numbers we'd be looking at over the next few years in terms of people returning and where they're going to? And then the second question I have is you talked about the factors influencing people wanting to stay in Vermont or come to Vermont after. And you mentioned housing and their spouses getting a job. You didn't mention healthcare, and I'm wondering how healthcare access for healthcare providers plays into this, and could some kind of system of universal primary care that guaranteed primary care providers an income while guaranteeing them and their family's primary care, could some kind of incentive like that also help? Thank you.
Thank you. So in terms of the awards, we have 25 awards that have been awarded. So over the next 5 years, we essentially have the potential to bring about five providers back through this program annually. We have 11.9 more awards based on the funds that are still existing. So we basically have the opportunity to add from this $1.4 million grant from the state 34, 35 total physicians coming into the state. That I think is good news. We have 59, I misspoke 2 weeks ago. We have, I believe it's 59 open primary care physicians positions right now. And so with that number coming in, plus 50% of the UVM family medicine residency residents staying consistently. So that's another 4 physicians annually, and Maple Mountain Consortium as it continues to grow over the course of the next several years. That potentially adds to, we're looking at almost 50 providers coming in. So that it is starting to move that needle in terms of bringing primary care providers into Vermont. In terms of access for primary care clinicians, we feel the burden of that just as much as our constituents do, all of our patients do. I have to wait 9 months to get my child their well child check, just like you do. I had to wait 10 months to get my preventative care screenings, just like our patients do. One thing that has happened at UVM Medical Center with the residents and fellows, it became such a difficulty to get new residents and fellows primary care, access to primary care, that they started a program that helps to get those residents and fellows into primary care practices within 6 to 12 weeks if they've identified themselves as being new clinicians. That is for the residents and fellows to try to help to keep them healthy so they can help to provide the care in the state. That doesn't necessarily include their families and their children, their partners and children.
Daisy, and then we need to,
Do you have your budget requests written out anywhere? I didn't see it clearly written out.
They are in my testimony, which I can submit to you. Yes.
okay, thank you.
Yeah.
Okay.
And I think they're on the VMS one as well.
I'll connect with you to make sure I have the right one.
All right, thank you, welcome, thank you so much. All right, Nolan, although you might have to make a small,
Yes, so I'm gonna have to, Ashley's gonna do most of the talking anyway. I'm just driving,
okay,
and at some point, I'm gonna get a text or Jen's gonna come over and I have to shoot across the hall real quick,
okay.
to testify in your bill.
Which one's her bill?
557, like your bill,
577.
577. So they did, and it'll be quick, but I just, so we're just, anyway.
Okay.
And then Tasha, if somebody could just drive for like the 3 minutes I'm over there. Wow, I really scared everyone away. We love doctors.
As we're sitting here going over the budget, thought it might be a good set to get a little bit of education on what exactly is global commitment. And Nolan and Ashley are gonna talk to us about it. So when we look at all these columns, we know what we're talking about.
And we say Nolan and Ashley, we mean really mostly Ashley, and Nolan's just driving and piping in here and there. Really shouldn't even have my name on this.
Really good at these graphics, by the way. I love.
I made this one. I made this one on my own. I'm quite proud of it.
And the EKG little.
Yeah.
there.
I was very proud of myself, but I'm not very artistically inclined. But anyway, for the record, Nolan Langwell, the Joint Fiscal Office.
And Ashley Berliner, Director of Medicaid Policy for the Agency of Human Services.
So yes, as we discussed, we're going to do a quick overview of global commitment. But I'm going to let Ashley pretty much do all the talking at this point. She's the expert.
Thanks, Nolan. So I know many of you have heard this before, but I agree that it's such a foundational document in the state of Vermont for how we operate our entire Medicaid program. I really appreciate you asking for us to come in and talk about the 1115 Global Commitment Waiver today. So an 1115 waiver is something that the federal government can issue a state Medicaid program, and it essentially allows states to waive some, though not all, Medicaid laws. Section 1115's waivers are intended to encourage state innovation in the Medicaid program, and they are often used for states to be able to pay for things that otherwise wouldn't be able to be paid for under the normal rules and laws of the federal Medicaid program. 1115 waivers are approved on a 5-year cycle, 5-year term, but demonstrations can be continuously renewed, amended throughout. The one core theme throughout all 1115s in the country is that they must be budget neutral. That is a statutory requirement. So you cannot spend any more with an 1115 waiver than you would have spent without an 1115 waiver. So for states that don't have an 1115 waiver, or if our 1115 waiver were to go away, we would be limited to being able to cover exclusively what is authorized in our Medicaid state plan, which is the mandatory and optional services in the Social Security Act and the mandatory and optional populations in the Social Security Act. Medicaid would have to be administered in strict compliance with all of those federal regulations. Next slide. So what does the waiver do for Vermont in particular? We have had the Global Commitment to Health 1115 waiver since 2005. It's evolved significantly over that time, but it continues to allow Vermont Medicaid to operate in two really distinct ways. It gives us federal financial participation, FFP, for populations and services that otherwise would not be allowed under Medicaid law. And it also allows us to have flexibility in the way that we manage our Medicaid program, the way we pay, the way we structure our provider networks. So federal funding and federal flexibility are really the core tenets of why we have around the state of Vermont. In terms of the federal funding, it gives us federal funding for this list of programs and services you see up here. It allows us to provide marketplace subsidies up to 300% of the federal poverty level on the exchange for people that are above Medicaid income limits. So people above 138% federal poverty up to 300% get an increased marketplace subsidy to buy their commercial insurance.
Can I interrupt you really quickly
Yes, please.
and ask a question about that? Is there a limit on how much our subsidy in that population is?
Yes,
There is?
yes, we can only go up to 300% federal poverty.
No.
You mean how many
There-
people?
How much money can we subsidize for that population from 138 to 300? Is there a limit?
Yes. The terms are in our 1115 standard terms and conditions. When we turned this on, we were the only state in the country that allowed marketplace subsidies. Now we have some company, Massachusetts notably, has a very generous marketplace subsidy program. But there is a limit. There are rules for what subsidies can be provided. There is also dollars in our budget neutrality agreement for how much we can spend on marketplace subsidies generally, like globally.
Currently, the way it works is we take whatever the folks are getting from their federal subsidy, and we're doing another 1.5%. So if we wanted to change that, we would have to go back to CMS and ask for permission, and it would make it hard. It would go against our cap, and so there's a lot of other considerations.
Okay. Thank you. Sorry to interrupt you.
No problem. Appreciate the questions. The Community Rehabilitation and Treatment, CRT expansion benefit. The Department of Mental Health is actually in the process of rebranding CRT. So that might be a term that you don't need to get too comfortable with, but it essentially means that we provide a mental health wrap benefit for individuals that are above Medicaid income levels who have severe mental illness, SMI. This is a really unique thing to the state of Vermont, where people who aren't Medicaid eligible but have acute mental illness or mental health need are entitled through our Medicaid program to receive wraparound services. So the Department of Mental Health administers this program. It's something we're really proud of. And it means that regardless of your income in Vermont, you have comprehensive mental health coverage. VFARM is a pharmacy assistance program for people over 64 in the state. So it reduces cost sharing for pharmacies. The Moderate Needs Group is a Choices for Care program that allows people who are not quite eligible for nursing home level of care to receive some level of services with the intent to keep them out of a nursing home level of care. So we kind of like to think of that as pre-long-term care Medicaid. IMD, Institutions for Mental Disease payments. There is a federal prohibition on paying for IMDs in statute for individuals between 22 and 64. We have an 1115 waiver that allows us to pay IMDs, both substance use disorder IMDs and severe mental illness IMDs, mental health focused IMDs, up to 60 days. So our waiver explicitly allows us to pay for Valley Vista, Brattleboro Retreat, the Vermont Psychiatric Care Hospital for stays up to 60 days. There is a arbitrary cutoff of 60 days per federal law. We have fought that tooth and nail and have not been successful at getting past that 60-day barrier. But it is something that covers all of our substance use disorder IMD stays and a good amount of the Brattleboro retreat stays as well that are under that 60-day limit. Children's palliative care services is administered out of the health department, and this provides palliative care services for children who are at end of life. We also have a long list of investments. Nolan has a link to that at the end of this presentation, but that is everything from paying for 211 to providing funding for the health department laboratory to paying for respite care for individuals who have family members that need respite. It's a really kind of broad list of services that we cover that otherwise wouldn't receive Medicaid match.
There's also a link to it on the website and on your website for today.
So that's the funding piece of this. And then on the flexibility, this is a little more abstract, but it essentially allows us to operate our Medicaid program as we do today with DVA as the public managed care like entity. So I like to contrast it with what most other states are doing. Most other states in the country, the vast majority, use private managed care organizations to carry out the functions of their state Medicaid program. So California, for example, has Kaiser United, who are these commercial insurers who are providing coverage to the Medicaid population on the state of California's behalf. That is the vast majority of Medicaid programs in this country. In Vermont, we, instead of contracting with private managed care, contract with DVA as a public managed care entity. And it allows us to take advantage of the same flexibilities that are in federal law around managed care. So federal statute really advantages managed care organizations and provides them flexibility beyond what a state could normally pay. Providers, it allows them to pay for things a little bit differently, have a little bit of a different provider network. So by using DVA as a public managed care entity, we can take advantage of all those federal regulatory flexibilities and still can keep it in-house and administer that program within our own state system.
And by the way, that's part of that mechanism is part of the reason why when you look at the ups and downs and it shows up as a global commitment on the, map together in one line, but you go to AHS and it's broken out there. That's part of that mechanism. AHS is the contractee or contractor. So that's part of why it's in two places.
So specifically, it allows us to pay our providers in ways that wouldn't typically be available to us under the state plan. So value-based payments, several of the mechanisms we pay, like the bundled payments that we pay, all of that is really using our managed care flexibility. It allows us to waive rules of statewide-ness, which really is what lets us administer our home health agencies, our designated agencies in the way that we do in these geographic areas because we can limit them to where you live. There are also waivers of the upper payment limit, which is a huge benefit to Vermont. Federal law requires that Medicaid programs have to be below the upper payment limit for Medicare in certain categories, such as inpatient hospitalization, outpatient hospitalization, and nursing homes. The 1115 waiver waives that upper payment limit so that we can exceed Medicare rates in those categories. And we do quite significantly in the inpatient hospitalization and nursing home categories because of the Brattleboro retreat payments, which are significantly higher than Medicare, and really skew that upper payment limit. And also our state-run veterans home in White River Junction really skews the upper payment limit on the nursing facility side. So if those were to go away, that would be a significant impact to Vermont's ability to pay for either of those facilities. Did we lose Nolan?
We lost Nolan for just a few minutes.
Okay.
But Tasha is ably sitting in his place.
Great.
And
We have a stunt double.
now, are we still the only state that manages our own Medicaid exclusively?
We're the only state that manages the entirety of our program. Arizona also manages a good chunk of their program in a similar way, but we're the only state that has the entirety of the Medicaid program under our waiver.
Have we done analysis over the years of whether it's more efficient, whether our providers are receiving better payments? Have we done an analysis on this as compared to other states that use traditionally a contract with a commercial managed care organization to
Well,
administer their benefits?
I don't know if I'm going to be able to answer your question exactly. We have done an analysis on whether or not this flexibility is beneficial to us. And one of the key constraints in Vermont is that we don't have the bodies, the lives to
Yeah.
pull in private managed care. Apparently, we tried it in the 90s and it did not work. It was not successful because we literally didn't have enough Medicaid lives to support it. In terms of payment to providers, that is wholly within the constraints of our state budget. So we actually would have a lot more flexibility to pay providers than a managed care organization would if it was within our state budget and authorized for DVA to pay out. That really has no bearing on the administration.
Okay, thank you.
Next slide. This is just a visual depiction of that private managed care like concept. So the Agency of Human Services is the single state agency, which is a term of art in Medicaid law, which requires the single state agency to carry out certain functions like determining eligibility for Medicaid, program integrity functions, and setting policy. And then AHS contracts through an intergovernmental agreement with DVA, who functions as this managed care entity. DVA then subcontracts with all of the other departments and AOE to carry out certain provisions of the Medicaid program. So of course, it's not DVA doing absolutely everything under the Medicaid program. DVA is subcontracting to DMH, to VDH, to AOE, Dale, etc. So all this is just a visual depiction.
Daisy has a question.
Ashley, something maybe more related to the previous slide. Can you talk a little bit about whether we can just continue to put all our programs into this waiver and get them matched? I mean, I know there's a cap. Can you talk a little bit about that? And also, who determines what we propose to add to the waiver, and a little bit about that process? And then the other thing is, once something is part of the waiver, what are the quality control measures like?
Those are great questions. So for the first question, we have that piece about it being budget neutral is really essential. So we have a budget neutrality agreement, which is actuarially certified, and it puts caps in place by population, by waiver only services, and by investment. So we have waiver specific caps for V-Farm, for moderate needs, for CRT, for the new adult population, for the kids aged blind disabled population. Every eligibility group has its own budget neutrality cap that is set in advance. So that is something that we really pay attention to and have to make sure we stay within, because that's the key kind of fundamental concept of the waiver that allows us to continue. So that's a really big constraint. In terms of, can we still add things? When the waiver is closed, as it is right now, so we have an operating waiver agreement, it's not in the process of being amended. We have investments that can be added throughout the course of that closed period. Investments are something that have evolved more than anything else in our 1115 waiver. When they were established initially, it was the wild, wild west. We didn't even have to tell CMS what we were doing. Now we are under a very close microscope. They are looking at absolutely everything. We have a very detailed application process for issuing new investments, and the criteria is extremely tight. So the last time we got new investments through was under the Biden administration. We have not received any new investments under the Trump administration. It is not an impossibility. We still have the option to add new investments, but we're under such close scrutiny, and we have such broad authority otherwise that it hasn't been something that we've been like really needing. If there was something to arise that felt like it could plainly fit in an investment category and we have very clear authority, then we would have the option to add that. So that's the second question you asked. And then the third question of who decides what goes in the 1115 waiver. That is a really timely question because we actually just kicked off our launch for the renewal. Our 1115 waiver currently is set to expire at the end of 2027, which means that we have to get an application in 2027 for CMS to review and approve to extend our 1115 waiver. So we have contractors that we've contracted with. We are contracting with the same vendor that we worked with during our last renewal, which was really successful. We do a lot of engagement with the commissioners to understand what the direction of their departments is. And traditionally, in a different year, not this year, nothing is traditional now, we would be doing a lot of stakeholder engagement to really understand, like, what is it that we need in Vermont that is innovative? What can we do to really continue to grow our 1115 waiver program and presence? This year, given all of the circumstances, we are playing defense and we are really focused on maintaining what we have. We have the best waiver in the country. I feel really confident saying that. And so we are not looking to add new things or put anything shiny in there that we don't already have. We really want to preserve the existing services and programs. So that's the framing that we're going into this next renewal and how we're thinking about it. That answer your questions?
Yes. I'm going to try not to say that it doesn't look in the budget like a lot of these are being preserved, because I see a lot of the investments are being cut.
Well, let me elaborate on that. So we're like a little bit out of, you're really jumping the gun on me here in these slides, but I think we can actually just skip to this part. So the 1115 waiver, as I said, it expires at the end of 2027. We are extremely worried about being able to get the thing, even though we're playing defense, we're extremely worried about being able to get these things through. They are really innovative. They are outside of what other states have. Vermont is a unicorn. We're out on an island. And so a lot of what's in our waiver feels like a long shot to get into the next waiver. Investments are at the top of the list of vulnerabilities. It is very unlikely that if we have to negotiate with this administration on our waiver, that we will be able to maintain those investments. So that is why the budget looks the way it does, is rather than cut programs that we think we'll be able to preserve in a future state, we're looking at programs that we think are not going to be preservable. We're going to have to cut if not this year, next year. That's really the calculus and why the budget looks the way it does. In addition to the fact that a lot of these investments, we stood up in a way, some back in 2005, that, and I don't want to speak to any specific investments, not having the list in front of me, but some of these were stood up in a way that didn't have really clear oversight over them, didn't have really good outcome measurements. And so we don't feel like they're necessarily doing what they were intended to do and aren't as effective as we want them to be. And so we feel like in addition to them being unlikely to continue in our new waiver, we're also not really seeing the return on investment in many of those cases. So I think both of those combined show you the picture of why those investments are showing up in the budget the way they are.
And when we first started doing global commitment, there was a lot of flexibility in what could be an investment. And sometimes we would just be like, let's make it an investment. And then the Fed started cracking down on us and providing more criteria, more specificity, and then in each continuing waiver, and even in the last waiver, now we can't even just create a new one without their permission. So it has evolved, and the amount of money that we can put into investments had decreased in the last waiver. It was like a step down in how much we can do for investments. What I will say is in that negotiation, AHS was able to negotiate some things that had been investments to become actual part of base. Like I think Blueprint was an example. And there might be, I think graduate medical education, another example of something. And I imagine in the future negotiations, some of those investments may become part of base. At the same time, we might lose investments altogether. So.
Yeah, that's absolutely one of our strategies is to think through the high performing investments and rather than have them as investments, which we know CMS has a lot of concerns with because they don't have much oversight, making them explicit waiver authority. So that gives them, there's a lot more guardrails and precedents around that when you move it into waiver authority versus investment. So that's one of the things we're really looking at as well.
Did you want to go back to the previous slide that we skipped over?
I think it's a helpful, if you go to the, after that one, Nolan. Yeah, I'm not going to read the slide because I already read it in terms of what the money is for, what money we're getting for the 1115 waiver. This is just a visual depiction of that. And it shows, I just think it's a really helpful reference guide for folks. Like, what does our waiver get us? The top half where it says allowable without waiver are things that even if our waiver went away today, we would still be able to pay for. The bottom half with waiver only are the things that are at risk or the things that would go away if we didn't have an 1115 waiver. So the administration, how we pay and how we administer, it covers the entire slide, but actually what we get dollars for, it's that bottom half of the slide that we're really going to be looking to defend going into our renewal.
Any questions go ahead, Leslie.
I'm just thinking about defending the investment, I think is the word you use, defend. And what kind of data do you use? How do you do that? What is the defense? Is it, that's my question. Yeah.
That's great. Nolan, do you want to take the slides down? I think we're probably good on those. So I oversaw the renewal in 2022. And I actually remember specifically being in this committee and saying we have no data on our investments. And I really did not like being in that position, going to CMS where we had no data on our investments, and yet we were asking for this really unprecedented thing to continue. So in order to remedy that, going into the next renewal, we established 2 contracts that we didn't have before. One is with the University of Chicago to provide quantitative and qualitative evaluation of about 40 of our investments that we think warrant that. And the other one is with the University of Massachusetts, who subcontracts with the University of Vermont to look at our Medicaid program as a whole, and therefore our 1115 program as a whole. So we are just in the early stages of everyone having all the data that they need, all the data sources, the sandbox had to be built, all these tech things that I don't understand. We're in the very early stages of them having that access, and now the evaluation experts in those universities can start to play. And so we anticipate later this year, before we have to go submit our renewal application, we'll have clear data, both quantitative and qualitative, on whether these investments are working or not. Like, do we want to defend them, or should we be pivoting and investing that state dollar into something else that's more effective? And then on the waiver side, are things like mental health expansion actually making anyone better off? Is pharmacy assistance for the elderly population making anyone better off? Are premium assistance subsidies helping people maintain coverage? Those are some of the questions that we're looking at more broadly. And I don't have answers for you right now. We started this in 2023 after our last waiver, like getting the RFP out, getting the contracts. And we're just now in a place where they have the tools and the systems and the permissions where they can start playing around and producing documentation and results. So I'm hoping we're much better positioned going into the next negotiation.
I'm sorry, can I ask, you said that you've identified 40, around 40, I think you said,
Yes.
of this long list of investments. Okay.
Yes, and some of them we didn't put on the list because we know they're just revenue enhancements, right? Like, we know that the public health lab has to happen. We don't need an evaluation of the public health lab. So that's an example of why that's not on there.
Yeah, go ahead.
Well, that's interesting to me, because why, if you have to have a public health lab, would it be in a potentially vulnerable position as an investment?
Because Medicaid programs don't pay for public health labs. That's a state function. So in Vermont, we've been able to leverage our waiver because we have this very novel and unique investment authority to pay for things that benefit public health that other states don't have.
So it's about the uniqueness of the waiver.
It's about the uniqueness of the waiver and the traditional uses of Medicaid, which the Trump administration has been very clear they want to get back to.
Right. And this analysis that you're about to do, where does it go? Is that something that we end up seeing, or how does that get distributed?
So the analysis on the investments, your committee actually has a report requirement for us. So we'll be getting that to you as it comes. I believe, I can't remember exactly how we structured the language. We're not getting all the investment evaluation at once. So it's like, as it comes, we'll be sharing that with you on the cadence that University of Chicago is providing it. And then the stuff that is more broad waiver evaluation, I would love to share with you when we have it. I don't have a really good sense yet on what exactly that's like, what shape it's going to take. It's not going to be a report in the same way that investments are. It's more like producing tables to fit into our waiver renewal application. So I think it would make good sense to come back next session before we start negotiating with CMS, as we're getting we'll have all this together and we can talk through the outcomes then.
Thanks.
Thank you. Thank you, Ashley and Nolan.
If I can just add
Yes.
one last thing, in the budget language, the governor's proposed language, there is authorization for AHS to start negotiating for the next wave. So just remind that there is a legislative role of giving them the authority to do that. And then the last thing I will say, and I think I would be remiss if I didn't say it, I think Representative Black's favorite line that I like to use.
It wasn't in the slides, I looked.
I know. Do you want to say it?
If you've seen one state's Medicaid, plan, you've seen one state's Medicaid.
Yes. And
It's a joke that just keeps giving.
just keeps giving. And the
That's
reason
not a joke.
and the reason is because every state that has a waiver, they all look different. We are I don't know if Ashley said this or not, but we're the only state that does most of our Medicaid program through 1115 waiver. So I will leave it at that. I couldn't leave it out saying, sorry.
Thank you. Thank you both very much.
Thank you, Ashley. That was wonderful.
Take care.
All right, let's bring up Mr. Fisher and Emma. Where's Alex?
Amy's coming in at 1.
Good morning. Mike Fisher, healthcare advocate.
And Gonzalez, health policy analyst.
And as we get ourselves set up, maybe I will just start with a recognition that we are here to do three presentations wrapped up into one. So that's just a little bit confusing. So we sort of organized it to attempt to do exactly that. We're going to kind of go through first our comments on DIVA's budget recommendation, and then give you an update on MSP Medicare Savings Plan launch, and then finally give our budget request. Make our budget requests. And here we are.
Yeah. That was a question already.
Our budget was,
HCA, Healthcare Advocate.
I know that. What do you mean by that?
I'll say more about it in the second half when we get to it, but the governor recommended a level funding for the Healthcare Advocate, and we are requesting $450,000 more.
So it's over above.
Yes.
All right. Oh, it's up there.
So now it's just going to click through to, did that slide. Just launching right in. We also recognize the tremendous challenge that DIVA will be under to adequately support Vermonters through the challenges that HR1 presented, and see DIVA's request for 12 positions, and think it is vitally important, if we are going to avoid losing a lot of people on Medicaid, that DIVA be well staffed. We work closely with DIVA every day on individual cases, on patterns that evolve, on outreach, and making sure that they and their contractor, Maximus, the HAYU, the Health Access Eligibility Unit, are well staffed and prepared to support Vermonters.
And so we're going to talk a little bit more about that. We are also going to be speaking to two budget items that we oppose: the proposed increase in prescription drug copays for Medicaid beneficiaries, and the family planning rate change not being implementable. So to say a little bit more about this one, so starting with the good things, we definitely support the funding of 12 new positions at DIVA. HR1 requirements, sort of as they detailed in their presentation to you last week, major changes in terms of immigration status, eligibility impacts, more frequent redeterminations for the expansion population every 6 months, which is going to massively increase their paperwork and processing, and work requirements for the expansion population. So all of those things are coming at us as a state, whether we want it or not. And we think that this is going to definitely increase the workload for the staff. And we think that Vermonters will suffer if DIVA is not fully staffed. Understaffing can lead to longer wait times for processing of applications. It can lead to eligibility errors when you're doing too much at once. You've got too much on your plate. And that ultimately can lead to unnecessary gaps in coverage for folks and even terminations when they should be eligible.
And let me mention, it is not in FY27, but as part of this overall effort, another very significant impact from HR1 is the loss of automatic re-enrollment for the QHP. That comes in the next year, but it is just part of this overall increase in challenge for Vermonters and need for a highly functioning DIVA.
Yeah, major increase in administrative burden. So we fully support this request of theirs.
And let me just say exactly the right timing in all of that of when, it'd be good to get from Diva the exact timing of all of that and when that is needed so that people are on board and prepared to do the supports in the right time.
Absolutely.
I don't think we asked. So the changes regarding more frequent redeterminations and the work requirements begins in January of 26.
So,
January
27. Oh, that's right. We're
No.
on 26.
I know, it's all wording.
27.
Yes.
And then the changes to the automatic enrollment for the QHP or the exchange, that will be for plan year 28, which will begin in November of 27.
Okay, a lot coming at us. All right.
so no surprise. And I did my sort of required thing. I called up Diva and said, heads up, we're going to be making this argument. So they're aware, maybe listening. We, of course, oppose increasing copays. And we note that it was described in the presentation here and elsewhere as a requirement of HR1. Would be curious to hear exactly how that's so. We don't understand that to be accurate. Yes, HR1 requires that there be copays, and Vermont already has copays of $1 to $3. So a decision to increase the copays is, I guess it's the next one. It doesn't make sense to us for various reasons. Even a $4 or $8 copay might not sound like a lot, but for the income levels we're talking about, it can be prohibitive. We see it be prohibitive, and then also, I think it was noted in committee the other day, or maybe the question was asked the other day. Yes, when we collect money from people for Medicaid programs, we share that revenue from low-income people back with the federal government. So we'd be
Right, so in order to save the state $461,000, the state is giving up or forfeiting $639,000 of federal money and transferring that entire $1.1 million load onto low-income Vermonters. And so that's going to show up for low-income Vermonters at the pharmacies. People are going to go to get their prescriptions and not be able to get them. People will ration their drugs. People will skip their drugs. But that's $1.1 million of costs that's being pushed onto low-income Vermonters. And just as some context, I did spend a little bit of time yesterday pulling, so 138% of the federal poverty level, which is the cap for Medicaid for children and adults. In 2026, that's $1,835 a month. I pulled the HUD, Housing Urban Development, 50 percentile rent for 2026 in Chittenden County. They monitor that for the entire country. One bedroom apartment is $1,769. So $8.
One bedroom, you said?
One bedroom.
1,007, what is it?
1,769. That's the 50% percentile. So there's more expensive and there's less, but probably worse conditions. And as we all know, housing is scarce in general. But my point is that people who are on Medicaid for children and adults do not have a lot of money to start. $8 is a lot for one prescription. And if you have a lot of healthcare needs and multiple prescriptions, like many people do, like I do personally, that adds up to a lot of money that you can't afford. And skipped healthcare is, as we know, always more expensive down the line.
I see Leslie. Were there any other proposals within the governor's recommend that would actually cost Vermonters more and give the federal government money? Other than this?
aware of.
I mean, yeah, we'll talk about, we have some slides on on the family planning rate
Right.
increase that the money we're not pulling down from the federal government. But I guess the last thing I wanted to say is just that I reviewed, so DEVA released their 2025 annual report. It's about 100 pages long. They released it last week. I went through it in detail earlier this week. I just want to note that this is against the background that DEVA's pharmacy costs are actually decreasing. So they note in the report, there's a $4 million decline in their net prescription spending by the state for Medicaid enrollees between fiscal year 24 and fiscal year 25. You'll also see in the budget line items that the VFarm projected savings based on you all expanding the Medicare savings program, allowing people to access that 100% federally funded low-income subsidy program. They are expecting to save the state $1.8 million over the course of 7 months. So drug spending is going down, and they have made a proposal to increase the costs for Medicaid enrollees.
Leslie?
So I probably asked, but I don't recall why they asked for this increase anywhere in, I don't know if it's living anywhere, but I didn't see it. I don't recall it. So maybe that's a question we can ask.
Yeah.
I appreciate you talking about the loss of federal funding, and when you just did your presentation, I think I need help at understanding what the cuts will lose us in federal funding and how to think about that.
And if there's one thing that we can be, that you would expect consistency from the HCA on, wherever we can, we're looking for as much federal participation, using the current, the rules to draw down federal dollars to help Vermonters access the care they need.
Yeah, I don't know if,
Are you referring to DEVA's testimony specifically on this?
I think I'm thinking about the whole healthcare budget and, all the cuts that they've recommended and how it impacts the loss of federal funding. I mean, this is just an example that, yes.
Yeah, sure, of course.
For the record, the whole thing will do this funds. I'll let the administration justify their thinking. But what I will say is that it's part of their structure on how they were trying to achieve saving reductions. I will also, and I said this before and I'll say it again, that's the thing about Medicaid, a double-edged sword. You're always leaving money on the table, but you also always have to commit money to do it. So it's always a double-edged sword. So I don't like to say we're leaving federal money on the table because we have to find the state dollar to do it. It's hard, that double-edged sword.
I'd just like to understand how much it comes, what the one side of the edge. That's what I'm just wondering. I mean, yes, we have to commit state dollars, but what do we lose in not making that commitment in a larger, and this is maybe not the right time because you're doing your presentation, but it just struck me that you brought it up, so.
Yeah. And our job is to stand up for the low-income Vermonters that are on. So,
yeah.
Understood the dynamic, and this is not a place we would support leaving money on the table or not drawing down this federal debt.
Yeah. All right. So the second major piece of opposition that HCA has to the DEVA proposed budget is the inaction or finding that the family planning rate increase that was approved by law in the last session is not implementable. So that was an just to jog folks' memories, that was an $85,000 general fund appropriation leveraged up to capture $765,000 from the federal government for an $850,000 gross investment in family planning. So states have been able to access the 90-10 match, which is incredible, for family planning services for Medicaid since 1972. That's more than 50 years. I won't say anything more about that. That is when the 90-10 match came into existence. We are learning now that has not been happening. And the inability to implement this code, we now know coding change, as was described to you last week in testimony, is costing family planning providers in Vermont $765,000 in foregone federal money. And what are family planning services? I think Representative Chena, you might have asked this last week. Just a quick review. Those are general reproductive services, birth control counseling and management, contraceptive services, routine primary preventative services such as pap tests. I believe states define those services within a set of guidelines. So Vermont defines those. And we do have a service list. We do have codes. We do have a family planning Medicaid program with codes. And we are very interested in working with them and learning more about where the barriers are to implementing those coding, any further coding tweaks that need to be implemented.
Brian?
Does family planning include any or all of the following, supportive counseling or therapy?
I do not want to speak to the long list, but I can send you a copy of the
Okay.
rest of Diva's.
All right, then I won't ask you all the things. But I'll tell you what I'm curious about. I'm curious if abortions are in there, and I'm curious if gender affirming care is in there, only because those are two things that are under attack. So if you send me the list, I'll look, but if you notice it in the list and you want to flag it for me, like, oh, you asked about this, like, that would help, but like, I'll look at it.
So we'll look at the list, but I think we can say confidently that abortion care is not covered by Medicaid. It is,
Thank you for clarifying
the
that.
state pays for abortion care.
Out of our own general fund.
Yes.
Thank you.
Yeah, and
Thank you for
family
clarifying.
planning services are going to be delivered by primary care doctors, primary care practices, and also Planned Parenthood clinics. But this is money that is going to your primary care providers as well. Many people get their pap tests and screenings for cancer and those types of things at primary
So
care.
a little bit, this is a principle thing. Yeah, $765,000 is, we shouldn't leave money on the table. We shouldn't not draw down money that's due to us. But a little bit of it is a principle thing. Medicaid should be able to do this. And if they are lacking the resources, if they are lacking the staff to be able to implement this and things like it, it's incumbent on us to make sure that they are staffed well enough to be able to draw down the federal dollars that are due to us.
Absolutely. And this is spending, Vermont is paying for this. This is not foregone services. Vermont is paying at a worse rate. So this is worse for the general fund. And that's why it's really important to prioritize situations where you are already paying for those services. The government is offering you a better rate. And you're saying right now, no, sorry, like to pay more. So this is really in the best interest.
It sounds like these are not controversial services. I think that's what I was getting at. Like, these are standard medical services that people aren't arguing that people need or don't need.
Yeah, family planning services are required under Medicaid.
And to be clear, the federal government is offering us a 90-10 match rate.
That is how important they are. The best match rate possible. So,
Thank you.
I'm
yeah,
looking at the list of codes. There is not one controversial code on there.
yes.
Oh, you found it that quick. Oh, you're a
Yeah.
coder.
Absolutely. Yes.
Where'd you find it?
Yeah, okay. Okay.
For the record, no language of this one. And I don't want to wait too much in on this. I just want to say that I did receive a memo from Diva on why it's complicated. I recommend that maybe the committee have them in to explain it to you.
Mhm.
I was about to ask that.
Yep.
How do we get around this problem?
Just have them come in and explain it to you.
Thank you, Nolan, for saying that. We will also be very interested in understanding why it's not in.
Yeah.
Yes.
And
Engaging with that as well.
we sure hope it can be.
Yes. And so really our recommendation is that, House Healthcare should ask Diva, why is it not implementable? And what can we do to help you implement it? Do you need more staff? Do you need more money for Gainwell to change their coding? Let's do it. Because again, the state is paying for these services no matter what, and we're paying at a worse rate right now.
Okay.
All right.
That's our comments on the Diva budget.
We're all fired up.
We're going to shift gears unless there's any questions.
Move on.
Okay.
MSP.
Happier territory.
Go ahead.
Yeah, so the Medicare Savings Program expansion, it's finally here. Legislators, you passed Act 113 of 2024, Act 27 of 2025. Those were the big budget bills. You also heard about the Medicare Savings Program in smaller bills throughout that time, and they all got rolled into the big budget bills. it's happening. Vermont's Medicare Savings Program was expanded on January 1st of this year. There's an estimated 14,000 Vermonters who will be newly eligible for this program. We are passing around our poster flyer that we've made. We hope that you will help us spread the word, because part of, getting the benefit to people is getting them to sign up and learning about the benefit. So just as some background, a quick sort of overview of the Medicare Savings Program. It is a Medicaid funded program that helps people with Medicare lower their costs. And people with Medicare are typically over age 65, or they're under age 65 and they have a recognized Social Security disability. They've been receiving SSDI income for 2 years, at which point Social Security automatically enrolls you in Medicare, whether you want it or not. And in 2025, so just in December, about a month ago, the Medicare Savings Program was capped. The highest income limit was 135% of the federal poverty level. So on January 1, the income limits increased. There are now 2 levels of MSP. There's QIMBY and QI1. QIMBY is capped at 150% of the federal poverty level, and QI1 is capped at 202% of the federal poverty level. A reminder that QI1, which is sort of the last column that you're seeing all the way on the right, is 100% federally funded. That benefit for Vermonters.
I think we should skim through this.
Yeah, maybe
I think just to
Yeah.
recognize that QIMBY does pay for Medicare premiums, and importantly, it pays for deductibles, pays for out. So it is Medicaid-like coverage. It's just a few tiny differences, that actually, in the great scheme of things, seem tiny. It can be very important to some people, but it's very much like Medicaid.
QI1 is different in that it only pays your Part B premium. So it doesn't help with cost sharing of the doctor. It doesn't, bring your costs to the doctor's office down to 0, but it does pay your Part B premium 2026. That's $202.90 a month. So that's almost $2,500 a year that you get to keep in your Social Security check. That is huge for people who are not living on a lot of money at a fixed income. And both QMB and QI1 automatically deem you eligible for the low income subsidy. The low income subsidy is the 100% federally funded drug benefit program. It lowers your Part D drug premium for Medicare, sometimes down to $0. It gives you all kinds of other benefits, and it drastically lowers your copays. In DIVA's budget, there's a line item that says V-Farm savings, 1.8 million for 7 months. That is because you have shifted most of your V-Farm population onto lists additionally, and so lists will pay first and the state second. So there are massive savings to the general fund because of that.
So DIVA automatically moved. So DIVA's been hard at work at this, as has the HCA. DIVA automatically moved 2 groups of people over the last couple of months. The first group was 8,600 people in December who were on an MSP program, but were newly eligible for QIMBY. And then more recently, another 3,000 people were moved into of the V-Farm areas were moved in. There's so much bad news out there. Everywhere we turn, there's bad news that people, there's risks of losing coverage. There's risks of, and people are losing coverage. People are losing key supports to be able to afford care. This is the incredible bright spot. In the next section of our presentation, we're going to be talking about the advocacy team at the HCA. We have these 8 advocates who are on the phone every day talking to Vermonters about the puzzle of trying to get the care they need. And there's a lot of hard conversations. There's a lot of bad news. I'm sorry. These are the rules. And even just selfishly for the Vermonters who are newly eligible, who get support, but also for the people, I just want to reflect for the people who support them. It's incredibly good news for the set of Vermonters who are newly eligible, and really appreciate that this committee was a leader for that.
Yeah, and it was very well timed with the exit of many Medicare Advantage plans from the state. A lot of those folks cannot afford Medigap supplemental plans, very expensive, many, many hundreds of dollars a month, and you're living on a fixed income. So, the MSP expansion was huge, just a bright light for so many people, and will continue to be.
So 14,000 people. Do we know how much, can you remind us again, how much the general fund investment was, and what is the estimated cost savings for Vermonters?
You're jumping ahead a couple slides.
Oh, I am? Oh,
So we were looking for the actual cost, and we noted in this year's DEVA presentation to you that the annualizing of the MSP was 2.8.
Yeah, so doubling that, we think it's the full annualized would be about 5.7.
Yeah. And to your point, it has an incredible return on investment. And, just to go through these lines, I'll just say for $5.7 million of state general fund dollars to be able to add value to this low-income senior and disabled population of $67.8 million is miraculous. I can't think of another place that draws down such support. The first line, the cost sharing savings, I want to be honest, we think this is very understated. We think it is much more, but but it's hard to actually get the number. The Part B premium savings, $34.9 million cash in low-income people's pockets. And that number is just a straight up $202.90 per month multiplied by the population we expect to be in there.
Is that the 8,600 population? I'm just trying to think about population.
How many people?
Does that across? Yeah.
Yeah, there's 14,000 people. So regardless if you get the Quimby or the QI1 benefit, you will get your Part B premium paid for.
So that's 14,000.
Yes.
2.6 is 14,000.
And then the last one, the 30 million, is a federal calculation of the value of the low-income subsidy.
Which is the drug benefit. That's 100% federally funded.
Yeah.
So it's really amazing.
So, I mean, we're not making a big push this year. We're not coming to you saying, hey, bring Quimby from 150 to 155 or 160. You probably, every time I'm before you, I'm going to say it would make sense to do so. But I think in fairness to DEVA this year and in recognition of the challenges, the budget challenges you guys are under, we are not making that push this year. But this is a place, you want to give free access to primary care. Here's how you do it for a key population. You want to, lower prescription drug costs. Here's how you do it for a key population. And you draw down a miraculous amount of federal monies to help you do.
Go ahead.
Very fast question. Is any of this at risk?
We are not aware of any risk. DEVA is submitting the SPA, which is a amendment to the state Medicaid plan. I don't know if they've already submitted it, but you can only submit it in the quarter that the effort becomes effective. Many other states have already done this and have increased the eligibility limits far higher than us. So that's why we felt confident.
Yes. Okay.
Really quickly, I'll just say, we have been super busy doing trainings. The HCA had trained our advocate team, those 8 advocates Mike mentioned. We've also done trainings with the SHIP counselors. Those are the Medicare counselors that work with Vermonters for free around the state. The agency, the Area Agency on Aging Consortium. We presented to the Medicaid and Exchange Advisory Committee the other week. My colleague Alicia and I did a major training for DIVA assisters for 40 or 45 assisters last week. We trained the Workers Center, which does events around the state at libraries to talk to people about healthcare programs. We're going to a conference hosted by the Champlain Valley Office of Economic Opportunity, and we'll be presenting on MSP as well. We are really hitting the ground running and trying to get the word out. And we hope you'll help us get the word out.
Which is me, that's you, asking you for your help.
Yes, and if anyone didn't get it, let us know, because we can send you all the materials.
My front porch forum.
All right, that's awesome. Yeah, people need to learn about it in order to sign up and actually experience the benefit of it.
I did too, and someone from outside my area thanked me for putting it.
Oh, that's great.
Able to really reach.
Awesome. Yeah, DIVA's been a fantastic partner along the way. We've been working really closely with them for the past year, gearing up for this big change, and we're continuing to work closely with them on notifications and outreach.
Hey,
Questions? Yeah, go ahead.
The low income subsidy,
Yeah,
it says here that you automatically qualify.
yeah.
You don't automatically enroll.
You do actually. So, and maybe that was a poor word choice on my part. So when you apply for the Medicare Savings Program, Vermont, and you are found eligible for Vermont's Medicare Savings Program, Vermont sends like a data signal to the federal government that you are automatically eligible for low income subsidy.
Is that new?
I don't know if it's new or not. I do think that there were some rules and requirements around that in the last year or two. But definitely it is happening.
Because it was a couple years ago that we had to actually like call people or
Push
take them
people?
off because they had not applied.
Well, so for the V-Farm program in the past, if you were under a certain income level, yes, the state of Vermont called you and said you are required to apply for low income subsidy. And if you apply through the federal route, there is a lower income cap and there is a resource test. So one of the reasons that this expanding the Medicare Savings Program is particularly amazing is that it functions as sort of a backdoor onto the low income subsidy program. The Medicare Savings Program does not have a resource test. It just looks at your income, and the income limit is higher. So many other states realized this long before we did, but we are getting caught up. And that's why now there will be incredible savings to the V-Farm program, because everybody who's on the MSP and V-Farm is automatically getting moved onto that
No, thank you.
federal payer benefit. Yeah.
We changed it to 150 last year.
That's where.
That's why we went
align.
from 145 to 150, just
To align with the low income subsidy. Yes. Yeah.
automatically
Yeah.
on list.
It's
You guys are
wild how it's all moving on the back end, but
Okay.
it's mostly good news.
It is.
List.
So listen.
Yeah. All
okay.
right. Okay, we're gonna move on to our last section of this presentation.
To state again for Topper, our base funding for the last number of years has been $2,406,000. That $406 I've always wondered about, but and we are requesting an additional $450,000. It's just the cost of it is the cost of running this team and continuing to do the services we do. There's just 2 points I really want to make for sort of to justify our request. Vermonters need us now more than ever. The last 2 years of open enrollment with the loss of Part C have been incredibly hard for Vermonters, hard for our team too, as they manage the system. And during those open enrollment periods, we've been busy as ever. And what's before us with HR 1 is, again, this just feels like, as you know, an all hands on deck. dynamic where we are going to need to be in the community and supporting community organizations and supporting Vermonters in new and different ways if we are to avoid losing Vermonters coverage. And then finally, wow, we've had a good run in the last couple of years. Our return on investment, our deliverables have been, frankly, don't hold us up to this in future years because this is miraculous. But we think it's, that the $2 million that you paid for the HCA results in $120 million of drawn down savings. And, a key piece of that is what we've been talking about, MSP. We've been working on MSP expansion for several years now, developing the case for it and bringing it to you, and doing community organizing, doing press work, building a coalition, really appreciate your partnership on that, and something we've worked on for maybe 4 years. Then also significantly the silver loading, Representative Rebecca's favorite term, silver alignment, I should say. This is the second year where we've been able to organize our marketplace in such a way to draw down an additional $53 million for Vermonters who get premium tax credits. And again, the HCA recognized this a number of years ago and advocated for it. This advocacy was not before the legislature, it was before the Green Mountain Care Board. Effectively, ultimately, we were ignored for a couple of years. The board went a half step that we told them wouldn't work and didn't work for a year. And it's now been in place for 25 and now 26. I don't feel confident that that will continue going forward. Just a heads up, the NBPP, the Notice of Benefits and Payment Parameters rule that just came out, I think may put this at risk for next year. And I think that DIVA and others are trying to understand exactly what the new rule will be. But for this year, it delivered an incredible amount for Vermonters. And then finally, it's only $3 million, which is a small number compared to the other ones, but maybe I'm underselling it. The $3 million, the savings that we get, that the helpline gives individual Vermonters who call us asking for help is maybe as important as any of the other numbers. Sometimes it's $10 that someone's saying, I don't know how I'm being charged this and I need your help. And the advocate figures out a way or determines that something wasn't done right and saves the person even just a few dollars or sometimes a lot of money in bills that they shouldn't be receiving.
Yeah, and I'll say, I think we, like the advocates, I've worked as an advocate for many years and I still take some cases. Advocates do not enter a dollar saved amount unless it's absolutely clear. So if you tell somebody that they're going to qualify for, the MSP and you're pretty sure they're going to qualify, you probably won't write down the amount unless unless they call you back and they're like, I did qualify. So it's vastly undercounted. And advocates also provide a lot of support that has infinite value, but doesn't have a monetary value, like helping somebody navigate a Medicaid transportation appeal that allows them to access substance use treatment where they didn't have a way to get to it. There's no dollar figure for that. It's just, but it's life-saving or altering. Yeah.
So we submitted this report to you. And it's on your webpage. And if you have more questions or want to read more details about the types of cases and hear comments from people who received our help, that's available to you. But I also wanted to you hear me say this every time, but I'm going to spend just a minute longer on it today. You see me every day. Probably like, oh my God, he's here again. When we're talking about Medicaid programs, I bring Emma with me. When you have prescription drug questions in front of you, you get Charlie from our team. You see Sam a lot lately on the corporate practice of medicine bill, but his real expertise is the hospital budget process. When you see that we're in the community doing a presentation or when you get a communication that has a nice graphic on it, that's Alicia's work.
The poster. Alicia.
And then you have when you call us and say, I have a constituent who needs some help. There's 8 advocates there who are supervised by an attorney. And I've left one person out, and that is when you ask us a numbers question. And we have to dig into exactly why something is working the way it does. Eric is our person we turn to. So you see me often, and I only do as good a job as I'm able to do because I have such a strong team.
I will try to get for you a dollar figure on the emotional relief that I personally receive. Every constituent email that I then am able to forward to you to help constituents. It's priceless. You're here, it's priceless. Thank you.
You.
Thank you.
Let's take a break until 11:30 and we can go off the live.